Okay, so now we're going to move into our next section. And I don't know if our other mentors are around. We changed the format just a bit. But if Rachel and Alexis and Vanessa want to just sort of come up so we can huddle together. In your packets, you have 3 scenarios. And our thought today was, we got, based on feedback from all of you, we're making this section more interactive. So you get to practice how to work with a complex patient. And so we have 3 different scenarios. I'll read the first one, and then I hope you're close to your groups of 3 with people you don't work with. That's one request, if you can. And do you want to read the first one? Sure. All right, so Vanessa's going to read go ahead.
The directions about the sheet of paper.
Oh, actually, why don't I, thank you. So in your packet, you should have, I hope, this piece of paper that says role play instructions. So the idea is that the person who hates role plays the most gets to be the observer first. And then one person plays a provider and the other is a patient. And then you're going to each get 5 minutes, and it's amazing. 5 minutes is short and it's long. So it's kind of an interesting perception about time. Yeah. And the observer's role is to look at the behaviors or the actions, either the physical movements or the words of the person who's the provider. Okay, they're moving into groups, yeah. So you're going to write what is engaging and what is distancing about how the provider's doing. And then we'll take just a few minutes after that role play to shout out what was going on. And then we'll do our next scenario. So thanks, Vanessa.
43-year-old history, non-gender specified, history of type 2 diabetes, mild alcohol use disorder, hepatitis C, and asthma, comes to the office for a follow-up. 4 weeks ago, the patient tripped going up the stairs and bruised ribs on their right side. Went to the ED where the x-rays were negative for fracture. Was given 15 oxycodone 5 milligram tabs in the ED and told to follow up with PCP. 1 week later sees your colleague as you were on vacation for 2 weeks, still having pain, especially with deep inspiration, though making an effort to practice deep respiration. Would like a letter excusing from work. Your colleague provides a rib belt, a letter to excuse from work, some extra strength Tylenol, and an additional 50 oxycodone 5 milligram to last until you can see the patient again. When you see your patient about 6 weeks after this initial injury, patient reports they tapered off the oxycodone, but the pain is still there. In particular, their asthma is acting up and coughing a lot, making the pain worse. On exam, patient able to take deep breaths without discomfort, no crepitus, has some mild tenderness to palpation along ribs 6 through 8 in the mid-axillary line. Requests more oxycodone and another letter to excuse from work.
All right, so I'm going to start the timer. I'm going to let you hold this. And then we are going to put up a few things if you get stuck. But I think all of you are amazingly skilled, so go for it. Thank you.
What's a rib? I'm also concerned about your asthma.
All right, folks, we're going to pause for a second. Who will volunteer what was engaging in your particular group? Did you take notes on what was engaging?
Yeah. Well, I liked how Doro was able to immediately kind of connect, whoa, that must be painful. And then when she was talking about how long she had been on the medications, she didn't say, well, that means they're not working. You've been on this long and you're getting worse pain. She just said, well, what do you think's going on? Kind of trying to get her to come to the conclusion.
Great. So asking questions. Here. What was a technique you saw?
There was initial empathy and some motivational interviewing that, with open-ended questions that tried to help the patient get involved with problem sharing and creating a partnership, and then imparting some objective information that would be helpful in exploring further options.
Great. We'll do one more.
Yeah, I just heard mirroring and rephrasing and reflecting on the part of the provider and summarizing questions like, tell me more about that.
Okay. So can folks who didn't find the engaging distancing, now I have a sample. It says role play instructions, so that's where it will be. Any quick questions or confusion about the idea of the role play? Are we good for the next one? Okay. So maybe I'll read the second. Mr. G is a 32-year-old Latino man estranged from his partner who has transferred care to your clinic. He's been taking buprenorphine, naloxone, 12 milligrams daily, which has helped him to stay abstinent for the past year. He recently moved to the area to take care of his ill elderly mother and start a new job. He reports high financial stress, commutes 3 hours round trip by bus to his job. He meets criteria for opioid use disorder and has a history of IV heroin use, alcohol use disorder, major depression, generalized anxiety disorder, and PTSD. He's also been prescribed clonazepam, 4 milligrams a day, and alprazolam, 4 milligrams a day. He's angry because he heard you're going to take him off his benzos. He states that without anxiety medication, he becomes suicidal and can't deal. So switch roles, and the observer will also be the timekeeper. I will do that as well, though. Thanks. Go for it.
Okay, hi, Art. How are you doing? Doing okay. What are you here for today? Well, I got a lot of issues again, and I heard they're going to get rid of my benzos.
A couple of whiskey, Jack Daniel, Capino.
That sounds like a plan, but I think that really...
So I noticed a lot of empathy coming from the doctor, some motivational interviewing. So there was a lot of not really open-ended open-ended questions, but kind of reflecting back what the patient was saying.
Okay. And how was that for the patient? Who was the patient? How was it?
If anybody knows Nancy, she can disarm anyone at any time. So I was all for getting off of benzos by the time that our conversation was done. But she's just so compassionate that it comes out, where it's about, my safety, and that she's concerned for me, and that's why. And that it's not an immediate take away. It's we want to support you in this process, and so.
Nice. Great. Rachel, do you want to read scenario 3? And then after this will be role playing up front for you.
So I'm going to add a bit to this scenario just to give it a little more dimension. So scenario 3, Ms. H is a 48-year-old Asian female with chronic low back pain following a motor vehicle accident at age 20. So she originally presented to established care after an insurance change, but let's say that was 4 weeks ago. So her history is that she meets criteria for fibromyalgia, major depressive disorders, recurrent severe, and opioid use disorder. Am I reading the wrong? Okay, anyway. And uses cannabis and nicotine. She's been on opioids for the past 10 years, including sustained release morphine, 60 milligrams, immediate release oxycodone, 10 milligrams every 6 hours. She is sedentary, spending most days watching TV, but will still run around and overdo it every week or so, and then I'm on the couch for another week. She is on SSDI as a primary source of income. She has 3 teenage children who also live with her. She states, I kind of want to get off opioids, but I truly don't believe that I can. I've tried in the past, and I just can't handle the pain. So at your last visit, you told the patient that, as you had discussed before, it was time to start tapering off or down on her opioids. So this is the conversation where the rubber's hitting the road, as they say, around that. Does that make sense? We just added that little dimension to it. So we're going to ask you to have this tapering conversation. And Alexis has provided, if you haven't seen it, this framework up here is maybe particularly helpful for thinking about how to walk through that conversation.
I don't know, something's off today. It's been hurting so bad.
Like the change.
Can anybody share, anybody notice some distancing behaviors with this role play? Did that come up for your group?
Frustration. So, but you were observing. I was the doctor.
What did you notice? Did you notice anything?
A little bit of frustration that she was able to, put in the bag. So yes, frustration, and I noticed that you used in your sentence the word "but," so that is a little kind of tug of war, as if improvising tells us you should have used yes and.
Yeah, thank you.
Anybody else want to share what they observed? Really? You guys?
Sure. You need a spokesperson. And, it was very hard when Ms. H was so focused on the prescriptions and trying to get the thought pattern over to something different than that, or at least willing to consider something different. It was really hard.
Yeah, it's hard. Yeah, thank you. So we're going to have our presenters come up, and I think we're going to start with scenario number 2. And I believe Alexis is going to be the provider. And have a seat here, and we'll get another microphone so you don't have to pass back and forth.
So for those of you who can't quite see, we're sitting up here. I'm going to try to do my best to be a 32-year-old dude. So I'm going to do some man-spreading. I'm going to lay back here. Okay. All right, here we go. Let's roll.
Hi, I'm Alexis. Tell me about what brings you in today, what I might be able to help you with.
Yeah, well, so I just moved here. I think you've got the stuff there. I just moved here. I got a lot going on, and you can see what I got there. I gotta get my medications, and then and I gotta. I got my bus pass is going to expire here in a couple minutes, so I just kind of need to get my medicine, and just can't really, talk a lot more. I just got to get rolling here.
Okay, so sounds like you want your medication, the anxiety medication?
Yeah. I'm all set with my subs for like another couple weeks, and I got those from someone else, so I'm all set there.
Okay, so you've been dealing with some anxiety lately. Tell me about how you deal with that besides medication.
I don't have anxiety. I mean, my issue, so I've got a lot going on. I just moved here, right? And
yeah,
my
it's
mom, yeah. And I moved here. My mom's super sick, so I got to take care of her. And then I got to work, right? So, I mean, I got to take this bus. It takes me 3 hours. I got to get there. I got to get back. I mean, it's not anxiety. It's just a lot of shit going on, and I just got to take care of it.
Okay, so yeah, a lot of things on your plate right now, a lot that you're dealing with, really stressful. And the medication has been helping for dealing with everything you have going on.
Yeah. I mean, the medication, my Klonopin and my Xanax, I mean, they help me sleep. Like, I gotta sleep. I gotta earn money.
Sleep is super important.
Yeah, I mean, my kids are still, back where I'm from, and I gotta earn money so they can come out here, because I haven't seen them. My girl, she's the light of my life. My son, he's kind of a pain in the ass, but I want to see him too.
Your kids are really important to you.
Yeah. So anyway, I mean, look, I just got a lot going on, and so I just kind of need to get my medicine, get out.
Yeah, it sounds like the only tool that you've had actually is to deal with everything on your plate, everything going on right now. Moving here, taking care of your mom, trying to get your kids back, this 3-hour bus trip, new job. Actually, the only tool that you have had is this medication. It sounds like you don't really have anything else to help you out.
Yeah.
Would you be interested in learning some more tools, having other things to support you in all this?
Like what?
So we have some classes available. We have some ways that you could learn other tools and skills that actually would mean that you wouldn't have to be dependent on just medication and could help you feel more in control.
No, you seem like a really nice lady. You're all, you're all mindful and stuff, but I mean, I'm telling you, like, I do not have time for that. Like, I can barely, I can make it here, I can make it to these appointments to get my medicines, but there's no way I'm going to be able to do that.
Okay, so you're willing to prioritize coming to these appointments?
Yeah, I got that.
Okay, great. So then that'll give us some time to work together. We can think about different options and things that might support you in all of this.
Yeah, that sounds
Tell me.
I think that's good. Is it the point?
Are we at 5 or can we keep going?
You have 34 seconds. Hit me. What do you got?
Tell me what else you'd like to focus on with our time. It sounds like you're willing to commit to and prioritize these weekly appointments.
Yeah.
What else would be good for us to focus on?
I get these nightmares. It sucks, and all this stuff comes back, and I can't stop. And that's why I can't sleep. And then that's why the medication helps. It's the only way I can get any sleep without waking up all the time with these.
So some nightmares, and it sounds like some memories that come back because of those nightmares.
Yeah.
And that's something that interferes with your sleep.
Yeah.
Okay, we can definitely look at that together and work on tools to help you with that as well.
Yeah, that'd be cool. That'd be cool. It's hard, you're on the bus all the time and you're just sitting there and these things come, flash in front of you, and I can't, I gotta get off that bus. I can't sit in there anymore. I gotta get off of that thing, and I can't, and I gotta stay on it because I gotta get to work, and then my mom, she's calling me and I'm on the bus. She's calling, like, when are you gonna get home? I'm like, lady, I'm on my way. I'm on the, so.
That was great.
So I saw some reflecting and some validating in terms of having a lot on her plate, or how important his children were to him. And then there was some coaching around the goals, and that she kind of was able to introduce the idea of prioritizing the medical appointment as a place to start working together. Any things on how it felt?
That's what really resonates with me, is when I'm trying to set up this barrier of, I'll come to your appointments. And then she immediately, that's change talk, I think is what you're hearing, or something there. And she grabs that and says, we're going to prioritize thee. And there's a connection. She was able to make this connection that I really felt.
Great. So should we switch? Or any thoughts? I mean, we want to do scenario, what are you guys doing? Three. Okay, we're going to do 3. Maybe we'll move on and do 3, and then we can have more of a dialogue with all of you. All right. And are you going to use your tools? Yeah, it's just, all right.
I'm the patient.
Yeah, use your tools.
Yeah.
Okay. We're going to work on that. Okay, so they're going to do this scenario already having had a few appointments together, so it's not the initial appointment. So the sort of trust, foundation, connection, engagement has already happened.
I'm going to try to use this thing for a second. Okay. Hey, Dolores, it's good to see you.
Hi.
Hey, how you been? How's the last month been?
Okay, I'm a lot going on with my boys. I'm worried about them, getting in trouble. I don't want them to get into drugs, and then they have to stay up at school, and I'm cleaning the house all the time, and
yeah,
it's been rough.
Are those things? Yeah, I mean, when we first met a few months ago, you mentioned that those things were a struggle for you. Are you still finding that?
Yes.
Yeah. And it's so awesome how important your family is. Really, I really admire that. Do you remember, let's loop back a little bit. Do you remember what we touched on last visit?
Mm-hmm.
Does that ring a bell? Yeah, what do you recall about that conversation?
That you did not think that the medications were as helpful for me. I've been thinking about that a lot.
Huh, that's great.
I mean, maybe you have a point. on some of those cases, but you know, because if I'm sleeping late and staying in bed, I'm not there in the morning to get, you know, because I mean, I get that that's really important, but it's been I just don't think now is the right time.
Okay, okay. What are you worried about with now?
I'm just still feeling, you know, extremely stressed, and then that means that my pain is extreme. Right. So I don't know, I think it's a good time to back down on my pain meds.
Right, right. And you manage an unbelievable amount, right, with your boys and with the work you've done to try to get to their games you've been talking about, with, you know, what you're doing around the house. I think what I'm also hearing, though, is that the medications may be getting in the way of some of those things.
But that's okay. That's a risk I'm willing to take.
Yeah, yeah. Would it be okay if we talked about risk for a minute? I don't know if we've ever really dove into that. Yeah, I mean, you know, 10 years ago when you were started on this medication, that was our understanding of what we thought helped pain. And we now know that there are other things that actually may work much better for your pain. My sense from you is that your pain might have, and tell me if I'm wrong about this, but this is what other folks have told me. When they got started on their pain medicine, it was maybe their pain was at an 8, and then maybe it went down to a 5 for a while, but over time it's kind of crept back up to an 8.
Absolutely, yeah, that's me.
Yeah, so that's helpful. So I wonder if you'd be interested in maybe talking a little bit more about other things that could get your pain from an 8 to a 7 to a 5, and that could stay there over the long term. And I want you to know that we're in this together, right? This isn't something that happens in a week, in a month, in 3 months.
What are some of those other things?
Yeah, well, I think what's more important is figuring out the things that are important to you that you want to change. And then those other things, we can apply those to the things that are important to you. This might look a little dorky, but we actually I have a sheet here that might help you to think about this a little bit. Would it be okay to take a look at it for a moment?
Sure.
Yeah, great. So here's a person, and there's a lot of things around this person that are important to that individual. It may be their lifestyle, it may be their mood, it may be their relationships with other people. So if you can circle some of these things that might be sort of affecting you and affecting your pain, and then that'll help us figure out some of these things that we might be able to do to try to help, again, to bring your pain down in a way that's gradual.
So I think for me, the lifestyle daily activities, like I think I'd like to be awake there in the morning when they're getting ready for school.
Yeah.
And I guess that involves the moving around and physical activity too. But I can force it, but then I'm going to be in bed the rest of the day, and I'm not going to be there when they come home. I mean, I'll be in bed.
Yeah, that's a huge one. So particularly around the lifestyle, the moving around, there's some pretty practical things that we could start talking about even today that might really help make a difference in the next week or two.
Are these things that somebody with my level of pain, though, could really do?
Yeah. So I'm going to flip to a different page here in my packet. Yeah. So here's one that some other people have told me is really useful to them, and it's this idea of these mountains that you're trying to climb, right? So here's you. You've got this big mountain you want to climb. Tell me all the things you want to do in a day. That's your mountain that you want to climb.
Well, I'd be there to be awake and talk with them in the morning, but that means cleaning up and getting the dishes in the dishwasher and getting all the laundry off the floor.
Wow, that's a ton. Yeah.
But I mean that makes my my back and neck really hurt.
Yeah.
It hurts a lot, and then I'm irritable with them.
Yeah. And then my guess is then for the next 2 days you can't do anything. Yeah. So that's a big mountain you're trying to climb, and right now what you're able to do before you get pain is kind of low down on that mountain. And then you get that pain, and it flares up. You end up
it gets so much worse. Yeah.
And when the pain gets worse, what's going through your head? What are you worried about?
That it's not going to stop.
Yeah, right.
And that I'm not going to get enough medicine to take care of it.
Sure. And maybe that you've damaged yourself. right? I mean, I've heard some people say that. I'm worried I'm making everything
Well,
worse.
I know that from the accident.
Yeah.
My back is a mess.
Well, what we know actually is that where you're feeling your pain, just because your body's gotten adapted to it, is probably far below this place where you're actually doing injury, where you're actually doing harm. So
What do you mean?
Well, I mean that you're sore and you're achy and you're stiff and it's uncomfortable, but you're safe. You're safe. That accident isn't affecting you anymore. So what we can work on.
So wait, so that means.
Yeah.
Because I think if I don't take care of my back, it could get worse and worse. That's why I didn't take.
You're worried. I'm sorry. Say that
again.
again.
So I need to make sure that I don't, hurt myself further. Then my pain will be worse.
Yeah. Well, again, there's a certain amount of. You have to go way up on this activity scale to hurt your back again. What you are now is. Your body's just gotten used to a certain level of activity and a certain level of pain that comes along with that. And what we can work on, and frankly, what the medicines probably aren't helping with, is getting you to a point where you get increasingly a little bit more active so that you're halfway up that mountain of work before you start to feel pain.
So I would be more tolerant of the pain?
Your response to the pain would be different. Think of it sort of as, oh, good. She's like, you're killing me. Yeah.
Do you want to finish your sentence?
It's hard. Yeah. I guess what I would say is your pain is, your experience of that pain would change, and you'd be able to do more activity before you started feeling that soreness.
I noticed how affirming you were, and also really giving some nice reflections around the value of family. I also liked how you asked the patient about, did you recall the discussion from last time, and then you being able to bring up the conversation about the medication. When you mentioned about being worried right now, that now was not a good time to go off of the medication, that you actually asked about, well, why are you worried about right now? And I think that was good, instead of dismissing that, to actually see if there were other concerns that could be addressed and to really clarify what those were. I think also asking permission before having the conversation about risk. When you did it, it was in a way where you mentioned, tell me if I'm wrong about this, really giving a lot of latitude for the patient to come in and insert their own experience. And the we're in this together, I think, was also helpful and engaging.
Yeah, I think it was interesting. I think that asking for a permission is not only respectful, but it also kind of forced me to say yes to what you were about to say, which I thought, I was trying to remain very skeptical. And I have to say, I don't know if I was entirely convinced that you were going to help me, but just to acknowledge that it takes, how much time it does take to do this. And and that, or just that it's okay to be skeptical, does it?
Great, thank you so much. So I'm going to ask, we have another runner, Rosalie will go around. Folks have questions, comments, concerns in the back, thanks.
So a lot of the patients that we've already seen a lot of other doctors before, how do we convince them that this time is going to make a difference and not like the other people they already seen and didn't help them or give them false promises or promises that just never materialize to improve their lives?
While you're thinking, I'll give one interesting thing. So there's I feel awkward sitting, a guy named Howard Fields, who's at UCSF, who talks a lot about expectation and learning and pain. And that if people, this is going to be a long answer question, I'm sorry, but it's really fascinating work, that if people believe they're going to get better, right, this sounds obvious, but you release endogenous endorphins with that belief that you're going to get better. It's the placebo effect. And conversely, if people believe that things are not going to work, some of those same anti-reward neurotransmitters get released, and instead of a placebo effect, you have a catastrophizing effect. So I think understanding where a patient is when they walk in the door is really important. And what Howard Fields says is one of the first things to ask is, do you think I can help you? You know, there's also, what do you need today? But I think that's a really, do you think this is going to help? And if they say no, then you sort of know where you're starting from. And I think you have to take, this is my usual answer, and Alexis will have more incisive things to say, but that just means you're starting way upstream in sort of their motivation to change. You can't jump into this conversation for months, probably. And that's provided, you know, there's not really, you're not seeing really scary alarm bells around their medications or their behaviors. I would advocate that that's okay, because they've told you, I'm really pre-contemplative about this, and it's going to take a long time to kind of rewire their expectation and their catastrophizing from this will never work to I'm feeling more optimistic that this will.
I would also just be very specific and concrete about what those false promises were. So giving them some time to be able to express the unmet expectations that they had, and then being really clear about what you can offer. And so that at least when they walk out of your office, if they don't like the answer, they're at least very clear about the limits in the offering, so that you're not setting them up for more disappointment around that. That it might not be the answer that they want, but at least there's clarity and communication. And yes, we can offer that. No, we can't. You know, I really wish that I could take away all of your pain. You know, but this is what we can work towards together. You know, these kinds of reductions, or these are the steps that we can take towards what's really important to you. So I think giving them a chance to air some of those unmet expectations, clarity about what we can offer, and really being on the same page around that.
And also just to remember, I mean, many of our patients have been traumatized by the medical system itself, and whether, you know, that's an ER or primary care provider or somebody yelling at them or not being nice. And it's a terrible self-perpetuating cycle. So they come into the clinic defensive, anxious, and just ready because they assume they're going to get mistreated yet again. And the way they come off, unfortunately, sometimes pulls people to do it again. I'm not going to give you that. You know, I know you went to 5 clinics already. There you go. So I mean, it's kind of like, hey, I'm here. The validation is just so important, and that I'm going to listen to you, and I'll be really clear about what I can and can't do to help you.
Also, within motivational interviewing, there's a piece around what used to be called rolling with resistance and now is called dancing with discord. And so I think that chapter can be really helpful with some of those techniques about how to engage with patients around that, as Vanessa's saying, who are coming in this place that would be maybe more defensive or more anxious with the expectation that they're going to be harmed again, potentially.
Okay, I'm going to write that down. Dancing with discord. That's good. Anybody else? I'm going to have Rosalie run. No, okay. Really? Any other thoughts, reflections, learnings? Okay, wait, we've got Rachel right there.
It's so brief, but we need so much time, which is the thing we don't have. And these things don't happen quickly.
So I agree with you, and I think that there are a lot of little small things. Engagement can actually be done with eyes and body language. It doesn't take, I think what I was hoping today is that you got some tools that actually don't take a lot of time. And you had 5 minutes, and you saw some things in 5 minutes that actually, I mean, that's what we're trying to do, is offer things that don't take a lot of time. You had another thought
Just
there.
a quick comment. I think it's worth writing down, do you think I can help you?
Do you? Yes.
And, you know, not necessarily ask every patient, but keep that question in our minds.
And that while these tools might themselves be employable in 5 minutes, but it doesn't matter. Even if you had an hour with that patient, it's still going to take over time to develop that relationship, right. And you know, so that they truly trust you. That it's temporal. It just takes. It's going to take weeks or maybe even months. And I think that's also part of. We talked at the beginning about compassion and empathy for our patients, and we've been talking a little bit about the patient's expectations of us, but there's also our expectations of the patients. And remember, they have the hijacked brain. Remember why they're so anxious, and that they might take longer than we'd like. But you can do things safe to mitigate risk, for example. So while you're waiting to very slowly taper down, you give a limited supply. Or if it's opiates, you're going to give them that Narcan kit to take home. You're going to give them homework assignments to do some recovery activity, or or one of these other activities. So I mean, it's not like just because you're going slow doesn't mean you're not doing that work.
Great. I think there was another. Do you still want to make your comment?
With the first scenario, what if the person was really not wanting to engage and just, that's it, I have to get on a bus, I don't have time, are you telling me that you can't give me this right now? Okay, I don't want to hear anything else. So what would happen in that kind of?
There was a moment where I thought about saying, it sounds like you're really pressed for time, that your bus pass is about to expire. I'm wondering if we should reschedule our appointment to have more time together. So I actually might just ask that question and give them the option of rescheduling if they came in that pressured.
And then when we did the scenarios yesterday, I think that issue came up, and when you were the provider and I was a patient, one of the first things you said was, I'm not going to reduce your meds today. But I mean, you're also setting expectation. Not like we're not going to ever talk about it again, but let's today focus on this initial evaluation.
Right, and the anxiety went.
Yeah,
you could just feel it.
And
so we were in Merced yesterday. Yeah. That's why with the Alliance serving Merced. Yeah.
But I do think it's okay, as empathic and compassionate and human-centered as we want to be, to say, I understand that, and these are really, and to express, I think, as Vanessa was saying, and Alexis as well, these are really important conversations about these medications. I understand we can't do that today, but can we agree to prioritize to have this conversation next time? Because I think who used this term, you don't want to feel that you are, that you're not a player in this relationship. You're an extraordinarily important player in this relationship. So I think being able to say, these are the boundaries I'm setting. These are the expectations I have. And sometimes those clear boundaries are some of the most empathic and compassionate things you can do, because that individual now knows exactly what to expect. As opposed to saying, oh, it's all good, and then the next time you're launching into this thing and they weren't prepared for that.
And I had a patient who presented for an initial buprenorphine intake, and as per our procedure, he'd been on buprenorphine already, started elsewhere, and so we need a release of info because we need to talk to your previous provider, and I can't give that to you right now, no, I'm not sure. And so we kind of described our whole program. The patient actually didn't need buprenorphine that day, which was kind of nice, so I didn't have to give a prescription, but it was like, we'll see you again next week, and by then we'll have had time to talk to your providers and all of this stuff. And they're like, okay, yeah, I'll call and give you the number. I don't have the number with me. The patient left, and it turned out that they'd been going to 2 different providers, because we ran the cures report. And I want to say on some level that patient was testing us out, and it was clear we had boundaries and rules which we were going to follow. And I'm really glad that we did that, because I think it would have harmed the patient if we were to give them their 3rd buprenorphine prescription. That was not helping them, or the community.
Great. So this is sort of our wrap-up time, and I just wanted to reflect a little bit what I think happened today. So the thing I was most struck with is the concept of engagement. And I think we all already know that concept, but I think all of our presenters really beautifully articulated what engagement can look like. And that breath as you walk in the door, just taking that breath, doing our own yes, there's a hand.
Physician assistant at the Community Health Clinic in Watsonville. And I've been coming to the seminars, I guess, since the beginning. But unfortunately, I don't see my colleagues here. What I find at our clinic is that we're completely burnt out. We don't have the time.
Yeah.
A lot of us have the intentions, but because of the burnout, they're just not interested.
Yeah.
And so, it's just kind of, people just come and go, or we push them away. And, unfortunately, a lot of people, our patients just feel that. A lot of patients just feel, they're hopeless. Don't go there. They're not going to do anything for you. I've been putting our extra time, at least on my perspective, to spend maybe 2 or 3 minutes, let's just, continue this conversation. I'll have you come back in 2 weeks. I usually do short follow-ups, but speaking from my colleagues, they're just burnt out. They can't do it. So, and I think that's just a challenge, than trying to address this concern is just that, the way the system works, at least with our clinic, It's just the time that we're given is just never enough.
I really hear you. And I think, I know that Central California Alliance for Health really has this on their radar. And we've been thinking a lot about burnout. I mean, I think Alexis had some specific things for burnout. But and I've been talking about this with Dr. Muten, I think that the team-based care, I don't know what's happening with your team, but for everyone on the team to have this, these tools that, I mean, I hate saying the word tools in the face of what you just said, which I just want to acknowledge is like the reality for many people and many teams, and it's really hard. But if we have shared language and a shared sort of revitalization and recommitment to the difficult patients we're serving, I'm hoping that that will bring us in that direction. But thank you for saying what I think is on everyone's minds and everyone's hearts. But I would argue, I don't think it's the longer appointments. I think it's revamping the whole system where, from the front desk to the medical assistant to, everyone sort of recommitted to what our values are and what our missions are. And so we've been having this conversation. I'm not sure a whole session on provider burnout will make a difference. It's really looking at the teams and how do we work together. That's my personal opinion, and I don't know if launching into a whole group discussion right now is appropriate, but as a community, we're all feeling the same thing, so you're not alone. It's not just Watsonville Clinic. I want to make sure that we're all in this together, and it's hard. Yeah. Anybody?
I just wanted to add that as a healthcare leader, I think it's the burden is on us to work to change the system, to create space for taking that extra time, for consulting with your colleagues, to do some of those techniques that Alexis mentioned that need to take place in the clinic. I was talking with somebody here about a challenging patient shared by specialty mental health in another medical clinic, and the two clinicians kind of saying, I don't have time to talk about it. But the patient is on multiple medications by both providers. How can they possibly provide the care that patient needs? So, I mean, I think but the problem is the system's not designed to give them that time. So how can we create that space and protected time for our providers to collaborate?
And I do think that taking breaths will help. Really, I mean, I'm a pre and a post where I didn't breathe, and then now I'm really consciously breathing, and it really helps. It's not just I'm not just placating or whatever the term is. It is powerful. Any other comments that you want to do in terms of wrap up? Or do you want to address what was just said? No, that's a big one. That was a big one? Yeah. All right. No? Okay. Yeah. Although I think you...
Sorry. I would just reinforce that idea of partnering really concertedly with who your payers are and who your health leaders are to do the type of transformation, particularly around team-based care, that really just leverages a lot of the opportunities that we talked about today, from having other people who are doing these tools, not just the PCP, to having time for consultation, to having data which are flagging who are your high-risk patients so you're prepared, so you're proactively reaching out to them instead of them being double booked onto your schedule. All of those principles of team-based care and patient-centered primary care homes. And so again, I'm not from this land, but if those are things that have not happened, again, I get the sense here that your payers are deeply invested in you having that type of transformation.
Thank you so much. And I really want to appreciate your comment, because I think it's exactly what is happening and why we're trying to do these sessions. So thank you.